This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 9, Burn Trauma. Key concepts. Upon completion of this chapter, you'll understand the incident of burn trauma, the types of burn trauma, pathophysiology of burn trauma, burn assessment, and burn treatment. Overview. About 1.25 million people are burned in the U.S. annually. 50,000 require hospitalization. 1 in 10 hospitalized will die. Death from burns is the third leading cause of unintentional death. Children ages 1 to 4 is surpassed by only motor vehicle collisions and falls. Difficulty to separate from smoke inhalation. 50% of the burn deaths will occur in the first 10 days following the incident. A large percentage of those deaths occurred during the first 24 hours. Chief concerns. Burns originate from several sources. Thermal burns result of an exposure to flame, steam, molten liquids, or contact with a hot object. Pathophysiology of burns, and this is a basic concept. The extremes of temperatures can disrupt the biochemical process and result in cellular injury or death. The body responds to stress of a physical insult by secreting epinephrine, norepinephrine, and vasopressin. Classic signs of stress are tachycardia, tachypnea, and hypertension. Consider the possibility of collateral damage to the core organs. Chemical burns, major classification, are from things like alkalis, acids, and biochemical agents. Common chemical exposures like phenol, organic acids created from coal tar through a process called fractional distillation. Hydrofluoric acid is another method, and these are chemical burns as well. Commonly used in the manufacture of fertilizers, pesticides, solvents, and high-octane fuels. Anhydrous ammonia, colorless gas with a pungent smell, recognized by most as a cleaning product for drains and oven cleaner. Calcium oxide or lime, caustic alkali mixed in cement in 2/3 lime concentration. And electrical burns. Physics for paramedics, and this is basic concepts again. Household electricity, form of technical electricity, result of a flow from a negatively charged anatomic particle called electrons towards a positive pole or ground. All substances allow the passage of electrical current to some degree in the body. The amount of current that passes into the body, functional of the electrical voltage and resistance, and this is Ohm's law. So everything conducts electricity, but some things conduct it better. Pathophysiology of electrical burns is the extent of the burn, and this is determined by type of the electrical current, whether it be AC or DC, the amount of current, direct contact, and the area of contact that was involved. History. Heat transfer, direct contact or radiation. It's important that the paramedic must obtain if the burn is secondary to exposure to fire or secondary to contact with burning material. A contact burn, determining if the object was a solid or a liquid, and the duration on this is also important. As far as history goes, patient with chemical burns. The key is to ascertain the offending chemical agent. Physical forms of what the agent was in, like it was a liquid, was it a solid, or was it a gas. Exposure volume, the amount the patient was actually exposed to, and the total time of the exposure. History, a patient with electrical burns, the mechanism of injury, the power source and electrical source, the current's pathway, and the contact duration. So this may require you to play detective on scene and figure out whether or not it was AC, DC, and then where the point of entry was and the point of exit was, because it will try to find a ground. Examination, initial assessment, mechanism of injury, the possibility of spinal trauma, and the need for manual stabilization. Routine initial assessment, signs of serious burn trauma. You should be getting a patient with hypoxic signs, open mouth breathing, gasping breaths derived from air, hunger, nasal flaring, stridor, which is a high-pitched audible noise in the upper airway or musical sound in the throat, or any other life or limb-threatening injuries. Examination continued. Chemical burns, hydrofluoric acid. Exposure will create redness, localized edema, and possible blistering. On the phenol, manifestation of a painless white covering made from precipitate proteins, anhydrous ammonia, irritating, causing burning sensation in the oropharynx and nasopharynx, as well as fits of coughing. Calcium oxide, corrosive effects upon the respiratory tract, causing a burning throat, persistent cough, and complaints of shortness of breath. Examination of electrical burns, distinguishing entrance and exit wounds is going to be critical. Difficulty due to variables such as the part of the body that might be affected, the surface area of the contact point, and so on. Point of contact, more helpful than anything else. What was the point of contact for the entry and or the exit? As far as burn classifications and assessment, the first one we'll take a look here is superficial burn. A superficial burn involves the outermost layer of skin, the epidermis, a red, moist wound that obviously blanches and readily refills is considered superficial. And that's what we're talking about right here. Superficial burn, it's still got good blood supply, and it's only involving the outer layer of skin or the epidermis. This is a partial thickness burn. A partial thickness burn extends into the dermis, a reticular layer of specialized cells and blood vessels below the dermis. Deep dermal injuries have molten cherry red color that does not blanch, and this is fixed capillary staining is why this occurs. The blood is fixed with damage to the capillaries in deep dermal plexus, and that's what this is we're seeing right here. This whole area here, do you see how this is already reddened in this area? What we used to consider a second-degree burn. So we have blistering that is popped. Depending on how deep this goes, this can involve multiple layers of tissue. Full-thickness burns extend past the skin's protective barrier and expose the body to infection and insults from the environment. So anything now has the ability to kind of overrun our own defenses. A dry, leathery, or waxy hard wound that does not blanch is full thickness. Deep burns sometimes are grouped into partial and full thickness burns together. And this would be the next association, or deep burns. Whenever we're looking at burn estimates, the total body surface area, and the easiest way to do this, or the best way to do this, and this is what the Burn Center uses, is called a Lund-Browder chart. It's the preferred method. It assigns body surface estimations according to a specific area. And this is a Lund and Browder burn estimate. So the head in an infant, 1 to 4, 5 to 9, an adult, head is about worth 7%. This is why sometimes we come up with different numbers using the rule of nines with what the Burn Center comes up with. And that's because they use what is called a Lund-Browder chart. How much evaluation of a first-degree burn, second-degree burn, and third-degree burn according to this calculation. This is the Wallace rule of nines, and this is what we're more accustomed to. Please be sure and look over both areas, Lund-Browder and the rule of nines in your book. So an example of this, using the rule of nines, the head would be worth 9%. And if we saw, as we saw on the last slide, that a Lund-Browder would be 7%. So that's 2% more. The front chest, 18%. So if they had this and this burned, it would be 18 plus 9. 27% as far as the rule of nines. Assessment of electrical burns. Electrical injuries may have limited external burn, yet have extensive internal injury. Complications, pulmonary, generally limited to the involvement of the phrenic nerve and diaphragm as far as paralysis goes, and cardiac ranges from sustained sinus tachycardia with global specific ST segment changes, so they can look like they're having a gigantic MI whenever this occurs. Atrial to ventricular fibrillation. Vascular damage, inflammatory response following the passage of electrical leads to diffuse mural thrombus formation, arterial occlusion, and ischemia of muscles. So during the vascular damage, what we can get is we can get clots formed, essentially, and cut off blood supply to areas. Abdominal, increased stress ulcers, hypodynamic ileus, and localized abdominal muscle injury. Treatment, first priority is personal protection and personal protective equipment. The chemical stuff, we don't want to take any of that with us. Universal treatment, remove the patient from the burn source, extinguish and remove the burning materials, perform an initial assessment, including ABCs, and determine the treatment needs. Do we need to involve the airway? Do we need to involve assist with ventilations? Do we need to take over? What do we need to do to restore the circulation? Smoke inhalation causes the majority of U.S. fire-related deaths. Mortality rate for 40% total body surface area burns. 3% increases to 27% on the mortality rate of the burns. Major mechanisms is going to be asphyxiation caused by oxygen-poor environments, loss of upper airway secondary to burns and swelling, and lower airway burns. Carbon monoxide and cyanide poisoning. Systemic poisoning is absorbed via the pulmonary tree, and these can cause profound hypoxia. Burns and hypoperfusion. Inflammatory chemical mediators released from the burns would cause edema and may create hypotension because we get a histamine release. Signs of hypoperfusion, tachycardia, and low blood pressure or hypoperfusion attributed to other life-threatening injuries. Identify and treat. On unstable patients, immediate transport, and many burn patients are relatively stable. Fluid resuscitation. Inadequate fluid resuscitation is a mortality source for most burn patients. Over-aggressive fluid administration, fluid creep, and may cause complications, may cause an increased burn edema formation, abdominal compartment syndrome, ARDS or acute respiratory distress syndrome. A balanced approach needs to be taken. Take into account the burn total surface area and maintain perfusion to the vital organs, the heart, lungs, and brain. As far as pain management, the source of burn pain. The stimulation of exposed skin nociceptors occurs primarily in partial thickness burns. Treatment of this is to assess pain intensity. Encase burn with impervious dressing, provide analgesia, morphine, fentanyl, things like this, and consider sedatives. Field dressings, categories. Interactive dressings work with the body to heal the skin. Non-interactive dressings are temporary dressings and must be changed. Wet dressings restrict use and give us problems with hypothermia and wound contamination. At the point that they have lost their ability to adjust their thermal regulation, a wet dressing could bring about hypothermia in a burn patient. Decontamination of chemical burns. Universal algorithm is to remove the patient from the source and remove the source from the patient. Specific considerations: anhydrous ammonia requires water immediately within seconds of exposure. Hydrofluoric acid, immediate pre-hospital treatment is potentially life-saving. Proper decontamination includes flushing of affected skin. Phenol, risk for secondary contamination via direct contact or through the vapors that off-gas from heavily contaminated clothing. Immediate decontamination can greatly improve the odds of patient survival and decrease morbidity. Calcium oxide, common lime found in cement, can cause serious burns. Most effective first aid on this is to brush away the calcium oxide, taking precautions to prevent the powder from spreading. Ocular burns. Chemical exposure on the eyes can lead to permanent blindness. May not fully manifest for weeks. Treat as a chemical burn and immediately irrigate with water. Treatment of electrical burns. Cardiac dysrhythmias. A pressing electrical shock complication. Ventricular fibrillation is potentially lethal. And if uncorrected, is lethal. More likely if the current passes from arm to arm, do we have a posing problem with ventricular dysrhythmias. Focus on the cardiac arrest in the initial assessment and their immediate life threats. Evaluation. The guidelines for burn resuscitation are based on a 24-hour time period. Associated third spacing of fluids does not take place in the first few hours. Hypotension during this first few hours, suspect the patient has internal bleeding if we do get hypotension in the first few hours. Disposition, first few hours of care, critical for the burn patient. In the U.S., burn centers, approximately 125 of them, transport any high-risk burns to these locations. Trauma centers and local hospitals manage the majority of these. Conclusions, burns, a leading cause of death. The paramedic must assess and treat regardless of the etiology. One constant, which is the pain and an outward appearance, can be distracting. The deeper and lethal complications can apply. So the deeper the burn, the more lethal complications and post problems that we'll see with this patient. References for this are taken from Myers Professional Paramedic, Volume 3, Trauma Care and EMS Operations. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@emsa.net, or 405-219-7613. Thank you.